Hi, gorgeous mums.
Hi, everyone.
One of the most difficult decisions a mum or a dad will have to make is whether or not to medicate their child.
Yeah, such a tough decision.
It's a huge decision, and sometimes it's necessary. And certainly sometimes medication can be an absolute godsend.
Yeah, it can really help some children, but for some children it actually increases their anxiety.
Mm-hmm.
So it's getting the right medication.
Absolutely, that's what this is about. I'm Dr. Nat.
And I'm Leigh.
We're from Love Your Beautiful Brain. We have a program online called Love Your Anxious Child, where we talk about a holistic approach to supporting anxiety in children, looking at the brain, the body and the gut. We were recently in Cairns for a conference.
Yes.
And we had the pleasure of meeting up with and actually doing a workshop with Dr. Ron Swatzyna.
I'm just going to share that now, his information.
Brilliant. From Houston, Texas. So he's from the Tarnow Centre in Houston. Now he was actually he was saying, okay, yes, we do need medication sometimes.
Yeah.
But we need to actually look at the brain to ensure that we're getting the right medication.
Yeah. And this is cutting edge stuff. People aren't doing that at the moment, even though we have the technology.
Yeah, and it seems like common sense.
Yeah.
It seems like common sense to say, okay, we should look at the brain before we decide what medication is the right fit. And this is why sometimes, and some of you may have been through this, sometimes you're given a medication or trialed a medication and your child's behaviour and symptoms actually worsen.
Yeah.
And that is because it's not the right fit for your child. So essentially this whole interview is about the importance of looking at the brain and determining, is this child right for this medication?
It's amazing stuff.
And it really is. It's part of our program, but we really felt that it was important to share this with all mums because I think it's information that everyone should know.
And it takes that pressure off about just making such a huge decision.
Yeah, I mean, the reason it's such a difficult decision is because a lot of the time they can't tell you why this medication is a good idea. And I think having this clarity will help you know that you're doing the right thing for your child.
So we hope you enjoy listening to Dr. Ron.
Fantastic. Thanks, guys.
Thanks, guys. Hi, everyone. Welcome to the Love Your Anxious Child bonus video. I'm Leigh, and this is Dr. Nat.
Hello.
And we are here with Ron.
Dr. Ron Swatzyna.
Correct. Thank you.
We're so grateful to you, Dr. Ron, for taking this time.
My pleasure.
Dr. Ron has a very large clinic in Houston. So a long way from home at the moment.
Well, I work for a very large clinic in Houston. It's not my clinic, but I do all the neuro
work,
investigations, research, and the treating director of the neurotherapy section of it. So
yeah, and Dr. Ron also does a lot of research in this area, and I was so privileged to be able to attend one of his workshops this week. And learn all about how the QEG and medication, or how the QEG helps us guide what medication might be more suitable for a presentation than not. Yeah.
Right.
I think I'd love to know a little bit of your history and how you got into this area.
In the years we've done 2,600 cases now, and I've published 13, 14 studies in the area of using EEG and QEG data in order to guide medication, looked at the prevalence rates of these spike and wave activity, the subclinical epileptiform activity.
Yes.
And found it in children with ADHD. There's a 32% prevalence rate. I think it's a little high, but then my population are those that had failed on medication attempts.
Yes. Yeah. Well, there you go. Yeah.
So
yeah.
So if your child fails on one or two clinical trials of a stimulant, it's likely that they've got these spikes. And we need to completely reevaluate the medication approach.
Absolutely, absolutely. It's interesting actually because while we've been on this trip, we've been doing some QEGs. So I think I've done 13, and out of those 2 had IEDs.
Good.
Yeah.
About right. We've got in our single case archive, data archive right now, we've got 1,034 cases, and 44% turn out to have these
IEDs,
spikes.
yeah. So what's a spike, Leigh? Say, what are you talking about?
Yeah, let's clarify that.
So it's called a.
Well, there's several things that people refer to it as. You can. It's a disruption in flow of data. Actually, it is a spike or a sharp wave. It's called an epileptic form discharge. It can use, we can call it an isolated epileptic form discharge. The newest, what we're changing out now to is subclinical epileptic form activity, which broadens the range a little bit, but it is a disruption. Now, what we feel is going on, and I published a paper on this in the fall, is that when these children, the most prevalent time for children to develop epilepsy is in their infancy, very young age.
Yes.
I feel what has happened in that time is those that don't have their first seizure, this activity grows over time in a process called epileptogenesis. And then when they move into puberty, the normal course of treatment for children that we see, and I'm sure in your country as well, they'll be diagnosed with ADHD early on because of attention issues, and they'll get.
And there's no wonder there's attention issues. I mean, the brain just goes offline when that happens.
I call it a blip.
It's a big bleep.
It's a big blip. And there's no way they can maintain focus, attention, and learning.
But they may have ADHD also.
It's not always this.
Right, so it's complex. And so then the doctors will prescribe a stimulant, and then sometimes it helps. Very seasoned, smart psychiatrists can nail it about 40% of the time and get it right, and that's great. And then they'll start developing some sort of anxiety / repetitive behavior of some sort, and then they'll prescribe them, diagnose them with an anxiety disorder, and then they'll put an SSRI on. And then as they start to approach middle school and puberty, they'll go for the behavior, especially in the boys, will get a little more out of range of acceptability, and they'll put them on an actual antipsychotic. So
we've seen this many a time.
When we see them come to us, and they're on 3 different types of medications, and these are some very strong medications, very scary for parents. The puberty is kicking in, and what we see is that, because I've done series on children, I've done some 7, 8 EEGs on children over time because I've been there so long. But what we see is this starts out as a little minor abnormality and goes into a sharp and slow wave discharge, and then goes, which means it's not as serious, and then it goes into a spike and wave discharge, and then it goes into a more paroxysmal all over the brain discharge, and starting in one place, and then it goes to multiple places in the brain, and then it spreads to the full brain. And I think that's why we have a 25% of the children that have spikes
will
develop and become epilepsy.
And has that grown? Has the percentage of people getting epilepsy increased, or children?
Well, I don't have the data to back it up, but my thoughts are that yes, it is, but it's because they're being put on 3 medicines that lower seizure thresholds. So I hate to blame the psychiatrists for doing this, but we know it's got a contributory factor because lower seizure threshold so much.
And so few psychiatrists will actually refer a child on to check their EEG before prescribing these drugs.
Well, if you refer these on to a neurologist or a neurology office, neurologists don't consider this activity as important.
No.
They discard it. They say it's a normal variant, which it is in about 4 or 5% of the population. But
it doesn't mean it's good for you.
But when you have adverse reactions to medications, and the medications don't work and everything else, and you have some clinical correlation of where it's discharging in the brain and where they're actually developing the behavioral issues to back up that this is affecting the brain. Paper out in 2011, Zimmerman and Konopka found that they weren't suspecting it, but usually we would think the more areas that it's striking the brain,
the greater the impact
for the psychopathology, the behavioral issues and the mood issues. They didn't find that.
Yeah, that's so interesting to me.
I know it. I was just really interested. So the ones that only hit one part of the brain or just a couple parts of the brain, they have the most psychopathology involved. And
so that means those children have more behaviour symptoms.
Totally.
Than someone who has epilepsy. So you can have full-on seizures, and they don't have mental health issues or learning issues. I mean, everyone knows someone who has epilepsy, and they're normally.
We don't treat many people in our clinics that have epilepsy.
That's
and
true.
So it's like, that is odd. We haven't fully figured it out yet, but
so it's because it's targeting just one area of the brain in such an extent that it's causing behaviour issues.
And I think it's because it's doing it more often. I mean, with a generalised seizure, they might have one a year. These blips, as they
Are
like to call
happening.
them, all the time.
Right now, we know that those that turn out to have epilepsy, have a seizure disorder on their first EEG, won't have any of these. 53% of them will not have any.
Wow.
So when we catch them, we feel like, well, that's pretty serious because
Yeah,
one out
because
of
it's
every
already
two we're going to
developed.
miss.
Yeah,
It's at
yeah.
a serious enough point that we need to consider
Absolutely.
changing medications and possibly consider an anticonvulsant.
Yes.
So,
And that is where you were talking about this in the workshop, which I found interesting because mums find it really difficult to medicate their children.
oh, I think it's a terrible thing to do.
Yeah. And there's and I think a lot of the reason for that guilt is because they're not given a reason for it. You know, they go with the child has behaviour and symptoms. The psychiatrist says, okay, this is the diagnosis, we'll give them this medication, but there's no why. This is why we're giving them this medication. This is what's happening in their brain.
You're trying to treat a symptom, not the cause.
Exactly.
Yeah.
Yes.
And that's a real issue, especially with these children's brains, because there's a lot of things that can cause similar symptoms.
Yes.
A lot of neurological abnormalities, and we got to figure out which one can cause that. Like I say, seasoned psychiatrists are really pretty darn good at what they do, but there are those cases that just don't respond like we expect. And I think those are the ones we really need to do an EEG and a QEEG in order to at least rule out some big bad things that can help the psychiatrist not make the child worse.
Yes. So at least they're getting the right medication.
Yeah. So is that starting to happen in America where they're using the QEG to determine what medication is best?
No.
Nice. So this is still really new. Even.
It's really new. We're the first private practice in the country to do it at this scale.
Wow.
And it's sad. You know, Europe is a little more not controlled by big pharma. So they're Martijn Arns and his study and personalized medicine and everything else is starting to, I think they're a little ahead of us. But I know I'm trying to get it in the United States big time right now. I think where we need to go is programs like this where we talk to the parents.
Yes. Because
And
then
say
they'll demand
parents
that.
go
Yeah.
to their psychiatrist and say, I'd like this test done. But then again, if you go to a regular neurology office to get the test done,
They'll say
they
it's
discount the
fine.
information and say it's normal,
Yes.
and you won't be any further ahead. So you
Yeah.
have to go to somebody like a
specialist.
practice that has an electroencephalographer that will look at it and say, and report the abnormalities and let the referring physician decide if they're clinically significant
Yes.
symptoms presentation or not.
Yes.
And so that's the big differentiation. I wish we could get it there quicker. I think doing this with what you're doing today is fantastic because you can get an idea to tell parents there is something out there. There is an option.
Yes.
We can keep them in a perfect world. It would be great that we don't have to ever use medicine and we could use something like neuromodulation, neurofeedback.
Yes.
But time is a factor a lot of times. And you have children that are in school and falling further and behind. And as soon as they start falling behind, their mood and their sense of self goes down, self-esteem goes down, and then they start questioning themselves, and then this behavior breaks out. And so sometimes you need to work the ligand-gated ion channels that actually work with the chemistry, the medication, and catch them first. Now, medication is, in most cases, it just works when it's on, you take it away, and the brain goes back to where it was.
Yes.
Except we have found one exception to that, and that's with all the work that we've done with the anticonvulsants on children. And it's a scary thing to think about putting your child on anticonvulsants.
Absolutely.
And there are some anticonvulsants out there that are absolutely terrible anticonvulsants that we do not like because of the side effect profile. But we have some now that are pretty innocuous, no side effects. And what we've done is we will have a child at 8, 9, 10 and find this activity and behavioral correlates. And then we'll put them on this medication and we'll get them to the other side of puberty. Because I've been doing it so long at One Center, we'll get them to their senior year, second semester.
Yeah.
And we use the EEG and the Q periodically in series to titrate the medicine to get it to where we can stop the activity.
Yes.
But we're not trying to control the seizure. So we're not using big seizure dosages.
No.
We're just using smaller dosages.
Yeah.
And so we stop, when we get them to their senior year, we check them. If they've got no spikes, we start the titration down, get them halfway off, do another EEG, no spikes. We titrate them all the way down, no spikes. It's done. It's actually fixed something. It's the only medication of psychiatry that fixes something. And we're doing a paper on that right now with Nash Boutros. Martine Arns and Rusty Turner and everybody. It's a big paper, but that's
Yeah.
what's been our experience with it, and it's been great to see that you can actually fix something, because if you kindle this, if you suppress this activity long enough, it goes away.
Yeah.
If you don't treat it and you continue to throw things at it that make it worse, like the wrong medications and the stressors of going through middle school and high school, it can blow up into becoming an epileptic. Then you got a seizure disorder person, and they can't drive and all this other kind of stuff that goes with it. It's just sad.
It's huge.
Yeah. If it can be prevented.
Yeah, and what you're saying is 25% of kids with these spikes may go on to develop
That's the
full-blown
research out there.
epilepsy. So,
And we've been doing this now since 2005, and we've had 0 become epileptic
with that
Wow.
regime,
with
Wow.
using the anticonvulsants. But we've had, I know of 6 cases that we didn't treat or that didn't want to go on anticonvulsants that developed epilepsy.
wow.
So we're trying to get the real numbers on that. We got to contact a lot of parents that got the recommendation but weren't. You
So
treat
you
it by
can
our
follow
center.
that up.
So we
Yeah,
follow that up.
yeah, yeah. Because
I
that's
think-
prevention. That's
That's
fantastic.
brilliant.
That's what you need.
Excellent. And it just makes sense to look at the brain and see what's going on first before you prescribe a medication that impacts on the brain.
Yeah.
It just seems like common sense, and it's so shocking that we don't do that.
Did you were you there when I showed that video?
Yeah, yeah.
You need to show that video
I
to
will.
parents.
Yeah, I'm going to load it on
Because
Facebook.
that's Harvard,
Yeah.
university study and everything else.
Yeah.
And she puts it quite well. We
Yeah.
need to look at the brain. We need to take this activity seriously, and we need to see some tremendous results out of it. And that's what
Yes.
we've been. We've seen some children that have just turned around their lives.
Yeah.
And like I say, you could do it with neurofeedback. It would just take a long time.
Yes.
But we find that when you do it with the medication and neurofeedback, the medication will stabilize the brain. The neurofeedback will lock it in faster.
Yeah. Okay.
And so the combination of the two is just really fantastic.
Yeah. Oh, that's amazing.
And do you ever use supplements as well alongside what you're doing?
Well, we do micronutrient testing.
Yeah.
We have a real issue with people just,
Supplementing
For no
without
reason.
knowing. Yeah.
do
That's
you
the
need,
same as medicating
do
for no
you
reason.
not? Do you need?
Yeah,
We don't
you
know.
have to
But it
test
has to be
first.
not in the bloodstream. It has to be the bioavailability into the cells.
Yeah.
Yeah.
So when we do micronutrient testing, we can tell what the bioavailability is. And when we get that, then we would only recommend what the body needs,
Yes.
not just, we'll use this, treat. They're using supplements like they do prescription drugs. You got ADHD symptoms, take this supplement. You got this symptom, take this supplement.
Yeah, exactly.
It's like, no, there's no rhyme or reason behind that.
Yeah.
You need to know what
We
those
need the science.
deficiencies are.
And I think also showing parents, this is your child's cell, this is what's happening. It motivates them, and then you have compliance. Whereas if you just broadly give out supplements,
Yeah.
they don't take them, because kids really protest about taking supplements.
And is that where you found doing some genetic testing and DNA testing has come in handy too?
Well, I think anytime we can bring science into psychiatry, we're far ahead of the game.
Yeah.
And so we do micronutrient testing. We also do the ALCAT test, which tests for food sensitivities, not just allergy testing, but the food sensitivities.
Yeah.
Because so many of these children's diets are so limited. I mean, it's sad. The worst thing I think they ever came up with was chicken nuggets, because that's all they'll eat.
Yes.
Yeah.
And I don't know about over here, but
That's
it's terrible.
Yeah.
And all the white stuff that they love.
Yeah.
And they're missing their nutrients that they need, and it really does work. I think it's responsible for a lot of the, what would we say, the maturationally lagged behavior,
Absolutely.
because the brain has to have the proteins, it has to have the good fats in order to myelinate, which speeds up the brain over time. So you get a lot of immature
Brain
behavior
development.
out of these children who have these very poor diets.
Yes, absolutely. Yeah. Yeah, so we find that very important, don't we?
Yeah.
That's Leigh's job.
We do a lot of education for parents about diet and why it's so important. And I think, once a parent understands what these nutrients are actually doing for their child's brain and how it's supporting them, then again, they're motivated to make that change.
Mm-hmm.
But I think it's all about understanding, and that's why we've done this program. We want parents to understand what impacts on the brain, nutrition, genetics.
So we talk a lot about epigenetics.
Epigenetics.
You need to talk a lot about sleep.
Yeah.
If a child doesn't wake rested,
Mm.
no matter how many hours they're down,
Yes.
there's a sleep issue.
Yeah.
Now, as the children, more so when the children age and they have their electronics in the room, I don't trust a single one of them. Those buggers. If you can't kill the Wi-Fi to your house,
Yeah, they will be on it.
Or a lot of them have the games on the phones.
Yes.
They need to have the electronics out of the room.
Yeah.
I've got a paper in that packet that we uploaded to the society. So.
Oh, great.
And it's one of the papers we just published for Houston Family Magazine.
Okay.
But it's on video gaming.
We'll attach that.
A terrible, terrible thing that's been going on with video gaming. We have found that since video gaming's advent, really 1994 with Mortal Kombat, male success rate in college has tremendously dropped.
Seriously?
Really?
Yeah, and it's now males have dominated universities in graduating rates until about 1981. They were equal with females. Now they're down 62% female, and 38%.
Wow.
And why? Because the males can't self-regulate the video games.
Yeah.
And they'll go to college and they'll be playing games all night long because they're out from under mom and dad's thumb. And they're equal numbers in college, but they don't walk the stage because they don't go to class. And it's terrible. We've seen a lot of them come back just defeated and everything else. And when you think about the role of video games, in the time when they're supposed to be developing their role identity, they spend all their time developing a cyber creature that doesn't exist.
Yeah.
And so outside of the games, there's no personality, there's no strength. You know, I say, well, why don't you go out and take a martial arts class? Why don't you go and do all these other kind of things instead of just pretending?
Yes.
You know, and so that's where the real issue is. Now, the violent video games, of course, desensitized to doing violent things. But we have found that for the most part, violent crime has dropped since the advent of video games, because I think that in video games, all you got to do is punch reset. Yeah. In real life, it comes at a painful cost. Yeah. And so most of them would just stay and play the game. So, but that's still no way to lose a generation of young males. Yeah. And there's a reason why males are more susceptible to video gaming than females. It's because their amygdalas are about 30% larger, and they get more of a rush out of it.
Okay. I always wondered that because girls
aren't
not
as much. Well, some are, but not all.
Not many.
So this is really, and then plus the fact that kind of stimulation for that kind of period of time really disrupts sleep. And sleep is the most critical thing to brain health.
Yes. Yeah.
And so I had a young boy that was a son of Indian parents, and we have this other pattern called beta spindles, which is just really
we talk about that in the program. Yeah.
And this young boy had a lot of beta spindles, and when I was doing the feedback with the parents and our psychiatrist, and I said that we found a link, thanks to the paper that Martine and I did, and Jake Unkelman, that there seems to be a link to that and sleep maintenance issues. And I said, does your son have any sleep problems? Oh, no, he goes to bed at such and such and wakes up at such and such. And then the boy, I was surprised, said, well, Dad, I actually do wake up in the middle of the night a lot of the times and play games for a couple hours. Wow. The father says, I'm not going to medicate my child. Let me get this sleep issue fixed. And he came back 3 months later.
And it was fine.
Sleep issue fixed.
So no
beta spindle's gone away.
Wow, that's amazing.
So,
yeah.
Address the sleep issue first.
Oh, wow. That's a significant side effect of lack of sleep.
Yeah, beta spindling is really significant.
Yeah.
And the impact it has on their behavior.
We've got about 20% of the cases we see have spindles, 20+%.
Yeah.
So
yeah.
That's pretty significant. But I do realize, we do know that children with ADHD traditionally always have sleep issues. But we got to make sure it's not a sleep hygiene problem, which is easy to fix.
Yes.
Compared to if it's an anoxic encephalopathy because of a lack of oxygen, because they can't breathe because their tonsils and adenoids are too big.
Exactly.
So completely different situation, but
or an
different
imbalance,
treatment.
Also an imbalance in neurotransmitters, like not having enough serotonin to produce melatonin.
Well, the melatonin needs to be suppressed by getting out the sunlight.
Yeah. And
getting that direct sunlight early in the morning. Then it will suppress your melatonin so that when it gets dark at night, it'll surge back up and put you to sleep.
Yeah.
A lot of these kids never get out of the house or never see the sun.
Yeah.
And so there's again,
another impact. Yeah.
What are we doing? We've taken a lot of the things that would make us healthy, and they're no longer in our life.
Yes, that's right. That's right.
We've forgotten how to live. Average talked a little bit about MTHFR earlier.
Mm-hmm.
So what's your experience with that? Is that something you look into?
Well, it is one of the biggest breakthroughs, I think, in science in regard to brain health in the last 5 or 6 years, and we use it quite extensively. The MTHFR gene is a valid gene, and it's in quite a bit of the population. And you can either have 1 or 2 of the genes, to keep it simply. Well, of course, 2 is worse than 1.
Yes.
But 1 is still really bad. But
Yeah.
what I ask up front before we do the test is, anybody in your family ever had a miscarriage? And if the answer comes back yes, likely that they've got that. Or if anybody in your family ever had a heart attack or a stroke in their 40s, 50s, or 60s. Same thing. It has to do with folic acid. And people with the MTHFR gene burn through the folic acid too quickly, and so they can't turn it into methylfolate to get it into the brain.
That was very enlightening, and I really hope that helped all our mums.
Yeah.
I'd like to see the feedback from that.
Yeah, you will. Look, it is so difficult for a mum to make the decision to put her child on medication, and I think sometimes it's necessary and sometimes it's not. I think making sure you do the proper assessment and you know that you're doing it for the right reason is the most important thing.
It is. Now, one thing I always say, and I tell everybody, especially all the practitioners I know, the best diagnostic tool we have in this industry is mother's gut.
I love that. We say that too.
We've got to trust these mothers. When they say we've missed something, we have missed something. We got to dig deeper. So doing a brain analysis like this is truly an opportunity to look inside and see really what's going on. And then you can make an informed decision.
Exactly.
Yeah.
And also the mother feels like she knows what's going on. She can see it.
Right.
Say, okay.
Now, the interesting thing is, I've done whole families. There's a genetic.
I know.
I'd love to get the moms and dads in there.
I know, we do too. Because often when we help the child, the mum will say, "Oh, can you help my husband?"
But I tell you what, if we treat the moms, we take care of the moms, the whole family operates.
Yeah,
better.
we do that.
Yeah.
Yeah. Mums, particularly with kids like this, very stressful and very tiring. So we see so many mums who are really struggling.
Yeah.
And supporting them always makes a big difference.
Great.
Yeah.
I think so too.
Thank you so much. We really appreciate it.
Enjoy it.
Yeah,
I would like to get a copy of this.
Yeah. No worries.
Bye everyone.
Bye,
See you next time.
everyone.